All right, hello everyone, and welcome to the April meeting of the EPEC Research Project. We have some great news after way too many back and forths and lots of late night discussions between me and our new guest here, Natalie Isha. I'm saying it right? Isha,
Show.
huh?
E-show.
Isha?
Yeah.
But okay, I was so focused on the inflection of the E show that I missed the long. I
No,
apologize.
it's all right.
Natalie E show. Tell me your actual title, Natalie.
I'm the Director for IRB Services and the Senior Research Specialist in the Department of Surgery at UIC.
And the queen of all things
Oh,
IRB. She left that part out. That's the part she
oh,
left out.
please.
We have been approved by the UIC IRB to get started with our patient recruitment. Thank you. Thank you to all the IRB guys that exist. But um, I did tell Natalie I wanted her here so that we could talk about some of the outcomes and what it means for the project. But I really wanted to thank her in front of a bunch of people because we could not be here if it was not for Natalie and her tireless efforts and our, what is it, 4 iterations back and forth with the,
Yeah.
it was a lot. So we had to edit a few things and we had to push a few things to a later portion of the timeline than what we had originally expected. So we will start by going through that. Actually, I should be sharing the screen. You go away and you. All right, so I definitely want to talk about the IRB. Then we'll talk a little bit about the subcontracts, which fits into the conversation about the IRB, what needs to go into the subcontracts. Then we'll talk a little bit about the CMS participant identification, review the timeline, and after all of that, we will go over that chart that I had sent you guys, the Excel spreadsheet that has those leverage points in it. Last time we talked about the clinical leverage points and it took a good long time. This time we're going to talk about those other leverage points. It's not all non-clinical, but most of them are non-clinical. So that's what I want to get through today. So what the IRB said, Natalie, this is your turn where you could just jump in at any time, okay? What the IRB said was that some of the pieces of our protocol are requiring some back and forth between the hospitals, between the research and the 6 transplant centers that are a part of the research. One thing about that was there's a flyer that we would use to post in dialysis centers that recruited people to the project. What we originally did was put the in a draft form. I would obviously ask for permission before we used any of those actual logos, to put all 6 transplant centers logo on that flyer, so that it doesn't just say UIC. What we don't want is for people looking at possibly being a participant in this project thinking that it's just UIC. And if they know they don't want to go to UIC, Dr. Akina is my doctor. I'm going to Loyola no matter what. Okay, Loyola is a part of this project as well. I just saw Dr. Sanjeev, so I thought I'd use it as an example. Hello. So we want to include that in a subcontract. I told them that we were not sharing specific patient information. What we were doing in protocol 1 was sending out a questionnaire to the transplant centers and then asking each one to answer the questions about things that patients might use in their decision-making process about selecting a transplant center. They said that is still sharing information that is not publicly available. And hence, you need to have that in the contract as well. Then we said we want to enroll patients for the entirety of Protocol 2, which we're hoping is 1 year. And during that point, we hope to get 350 patients. But the later into the enrollment period that we get, so further into 2024, the more difficult it's going to be for us to enroll somebody and actually get their information about when they were when they went in for evaluation and when they were listed. Now it's possible we'll get the majority of that information, but that's just one outcome. Another outcome is, were they transplanted, and were they transplanted faster because they selected the right transplant center for them? That's way out past the 1 year that we'll be doing the enrollment and going through the EPEC project. So we put in a 5-year participant follow-up period. That does not mean that this crew sticks together for 5 years. That means, and we also didn't want to put the burden of follow-up onto that patient. So we said that we would ask the transplant centers on a monthly basis what patient, we'll give them the patients and say, have any of these patients been listed? By the time we get started on the follow-up period, it'll probably be like 300 patients that we have to say, okay, we know this patient took part in it. Are they listed with you? If they're listed with Christ, now that I see Dr. Chhabra down there, hello, Dr. Chhabra. If they are listed with Christ, then we know to just follow up with Christ and say, hey, is this patient still on the list or have they been transplanted? And we do that once per month, all the way out for 5 years. Once we have one contact person, this will be way easier. It's just the storming and norming period that happens at the beginning of any process. But that will allow us not just to see if we are impacting the patient's ability to be listed, but to see if we're impacting the patient's ability to be transplanted. That's a secondary endpoint, but still something that we believe is important. So that is what we need in the subcontracts for the IRB to give us permission to go and start enrolling patients in Protocol 2. Now, Natalie will tell you everything I got wrong.
You said it pretty well, actually, so there's not much I have to revise from what you're saying. So the IRB has a provisional approval for procedure 1, so we can start the research. The procedure 2, we have a little bit of a holdup with these subcontracts. So the IRB will approve procedure 2 to start as soon as we get these subcontracts in place. As he was saying, he wants to, include a couple things, and this is something that the IRB would like. approved, because obviously the use of logos from different institutions has to be okayed. They also want data use agreements to go with the subcontracts, which I believe they will be. So that will be something that has to be included. That would be part of the data sharing portion of this. I saw in their request as well that they wanted IRB approval from each site, but I'm going to touch base with Ibrahim about that, because I think we resolved that.
Yeah.
And then I reread it and I'm like, I don't think we have to, because we have these subcontracts in place along with DOAs. We normally don't need to go ahead and do that, but I will touch base to see what else they need from, if they need anything specific from the institutions, and hopefully that won't hold us back. The rest of it should be fairly straightforward. There was a couple other requests that we could get, done quickly, and then we can get that going.
I was close. So those subcontracts, you can understand those are critical. So that's why I sent that email out to say who's the contact. I saw some of you have responded. For those, the transplant center representatives, if you have not responded, please do. It's critical that we get this done
Stuff we work
as early as we
that's
can.
him. He's director of the media and all of that. That's him. He's in charge of all of that. This Brad's brother.
Where's that coming from? I can't tell where that's coming from. Anywho, so Aaron and Brian's last name is somebody help me. Bacon, thank you. Aaron and Brian Bacon will be the contact persons to get the subcontracts done. So you'll see emails coming from them. Please, provide them with the information that they need in as timely a way as possible. We know this is not going to be easy because it's a contract and they have to go through all the appropriate places. But again, we can't start protocol 2 until we get these contracts in place. I'll stop there and see if there are any questions from anyone. And I know we've been talking about this a lot. If there's anything that you think I haven't spoke to that we actually do need in the contract, knowing your organization, please let me know that as well. An example would be, we're going to ask the OPTN for information, but that OPTN information is public information. So once we go through and get permission from HRSA to use that information, we get it. If you know that your organization is a little bit iffy about who does what with their OPTN information, please let me know that, so that if we need to put that into the contract, we can. But that's just an example of things. And it doesn't have to be now, just anything that you think, what I've heard Ernest talking about thus far, or what I've heard Dr. Jones-Manson talking about so far. I think we're missing a piece that needs to be in that contract for my organization to be comfortable with it. Shoot an email to me, and I'll make sure that Brian and Aaron get it so that we can keep working on it. All right, hearing no questions, Natalie, you are free. Thank you for coming today, and thank you for all of your help thus far. You're not done yet, but I'm saying thank you now.
No, you're welcome, and nice meeting all of you virtually. Take care.
Likewise.
Bye-bye.
All right, the other thing that getting our IRB approval means for protocol 1 means that we can start the survey that Dr. Jones-Manson has been working on thus far. So everybody did the pilot survey. Thank you. We made a couple of changes for Dr. I think it was Dr. Josephson. Dr. Josephson specifically said that she didn't really see the blatant difference between that first part of the survey that is asking the professionals and the patients, what is it that was shared with you or what is usually shared with you that you felt was helpful? And then the second part of the survey that says, what information that usually is not shared with you did you think was helpful? Dr. Jones Manson made some changes to the survey document to try to make that more particular in the way that it's shown. What were those changes you made, Sandra?
So we just used, I think one of the patients recommended it to just some bolding and highlighting to the language in the introductory text. And then within some of the questions that were very similar, we use the same features, bolding and highlighting to show the difference between those particular questions.
Perfection. So we believe that we've done everything that we said we were going to do to get all of the advice that you guys have given us, and we are ready to launch that survey. So our plan is to get that started next week. And what I wanted to do was go over, now I have to stop sharing because I have to go to my notes. Everybody gave some helpful hints as to there we go. Everybody gave some suggestions as to why can't I push this to the other screen? How weird is that? It's okay. I'll just move it to the side and I can still see your beautiful faces. We talked about the dissemination of the survey. So I'm going to go over the people that I had from my notes. If there's anybody I forgot, please remind me. If anybody else comes to mind, please remind me. I had the NKF of Illinois. I had the American Society of Nephrology. I had the American Association of Kidney Patients. I had TRIO, which is another patient organization. Then I had the SRTR Patient Committee, which is probably about 20 patients, but they're very active nationally. I had, actually, we didn't talk about this one last time, but I thought, is it possible for us to put a flyer in the transplant clinic waiting rooms? I see Sanjeev shaking his head, but for physicians, is that a reasonable ask if I was to create something? I could even have it printed and shipped to you guys. Is that reasonable? Do you have somewhere for it, or is it going on a wall, or what?
Might go on a wall, at least for us. I'd have to, I'm not sure exactly where it would go, but we probably could find some place.
Okay. Dr. Chabra, you guys have some place for it at Christ as well? And I think that,
sorry, I was having a hard time unmuting. I'm sorry, Ernest, would you repeat your question?
it's if we were to print off a flyer to ask patients to take the Protocol 1 survey, could you hang that up in your clinic space so that
Oh,
patients...
absolutely. Not a problem at all. Not a problem.
Awesome. Perfect.
And then I'm still trying to find out the right person for the contract. As soon as I have that, I'll get you connected. And then, to approve the logo and things like that. I'll follow up on that, not a problem.
Awesome. Thank you.
Ernest, another common place that could be posted in a clinic is like on the windows for where the patients register when they come in.
Oh,
Frequently you'll see things posted there as well as on the wall. So that might be another place to consider in the clinics.
awesome. So now I've been to so many transplant centers recently, and I have not been to the UIC transplant center since they've done their remodel. Actually, they moved, if I remember correctly. Pierre Paulo, are you still there? Can you hear us?
Hi everyone, sorry for connecting late. Yes, I mean, you should come.
Yeah, I will get there. Is there somewhere for us to post this if we were to print it out?
I would believe so. Yeah, I'll talk to the team, and yeah, I mean, there is the reception area, of course, where all the transplant patient wait, and yeah, that will be really
Awesome.
possible. Yes.
Aaron, I'll send the data to you to create a flyer, and we will work on. Now the question, I'm going to give you more homework, Sonja. I'm sorry. The question would be, can we create the QR code so that the patient could just put their phone up to it, click it, and it goes right to the survey? Don't put too much effort into it. I want to get this out next week, but if we can figure it out quickly, I'd love to do that. And then Aaron, you and I meet tomorrow. We'll figure out what the flyer needs to be and get it printed out and mail it to the attention of the specific physician so that they know what it is when it comes and where to put it. Make sense? All right. Others on the list were the ESRD Network 10. You guys have a lot of patients that are associated with you. Roma, can you hear us?
Yes.
Is there a mechanism that we have to go through to get this, ratified, or can we just give it to you and get it out to people?
Yeah, it would be easier for us to just get something that we can send out because
Okay.
we use Contact Manager and it'll catch all the facilities.
So like email, sends you an email and then that email goes out, or sends you a flyer and the flyer goes out? What's
Either or both. We can attach like the flyer to the email and then like the body of the email still included. That way we can catch it both ways. So yeah, either way works.
Okay, we're gonna do both ways to make it easier. Okay, I saw the chat was lighting up, and Dr. Jones Manson had the renal disease. So AST I talked to. I'm not sure I'm going to use them for this. I know I said it last time. Might not be using them for this. The UNOS. Okay, yes, that was from Valinda. Let me put that on the list because you sent me that list. Thank you, Valinda. And UNOS and OPTN, kind of the same thing for now. And what's RFA?
I'm not sure. I was just writing as quickly as I can.
Okay. What's AMAT, Belinda?
It's the Association for Multicultural Affairs and Transplantation.
Do you have a contact for them?
I can get one.
Okay.
And transplant families, is, familiar with them. And did we have TRIO on the list?
You said who?
TRIO.
Yep, Trio's on the list. Yeah, I
Okay.
have a meeting with Lorinda coming up.
Yeah, I'll see about getting a contact for AMAT. I know some past presidents, but I don't know who the current president is, so let me research that.
That is pretty wide dispersal, my friends. I am comfortable. Oh, Dr. Josephson. Okay. I will follow up with her. I know she's in clinic today. Renal Physician Association, probably that.
Possibly, that makes sense.
Okay, let me add that to the list. Okay. Any more places? Speak now or forever hold your peace. All right.
Did you have DPC,
Who?
Dialysis Patient Assistance Group? The one that Quinn posted in the chat.
How did I miss it?
DPC.
I don't see. Oh, there it is. Yeah, I see it. Nope, I missed it. Thank you for bringing that up. You're a doctor. Of course your handwriting is bad. Okay. Next on the, okay, Soldier, did you have anything else that you needed to bring up about the survey?
Not at this time.
Thank you, ma'am. Love to have you stay. Free to go if you have to.
Well, have a great
Um,
evening.
All right. Oh, next. CMS is being exceedingly and exceptionally difficult.
That's
So
what they do best.
my contact that was there left recently, which leaves me lurching in the water just a little bit. I don't have my back door that I used to have. So now I have to go directly through the people with the granting mechanism. And they keep pushing me over to the not the USRDS, but the CMS payment system, ResDAC. They keep sending me to ResDAC to find patients. And I'm like, it's at least a year behind. And it doesn't have patient contact information. We really, really need to be able to go directly to the patient, and you have all of that information in EQRS. Just give us access to that. And they have said no. So I have requested a meeting with the leader of EQRS. We've had a previous meeting with their core, which is oh God, what does core stand for, Roma? Help me. I forgot.
The
Contract.
CMS or the operating representative or operations
There it is.
representative.
Contract operations representative, something like that. And we need to go above that person. We need to help them understand not only are we a grantee of CMS, not only did CMS say that our protocol that we presented to them was viable, but this is the right thing to do for the patient, which maybe I'm just head in the clouds right now, but it's got to happen. Let me not say that. I used to say it's got to happen. And now I'm saying I really, really hope it can happen, but we need to start to develop a contingency plan. Right now we're in April, and if everything in the timeline goes as planned, we'll be starting to bring in our first participant August 1. So we need to have a mechanism for recruitment in place by August 1. If we cannot use the relationship with CMS to do that, we have to lean on that secondary idea that was posed by the ESRD network, that we kind of work directly with the dialysis centers, which obviously we know this is not in their best interest, right? We are doing our best to get the patients out of dialysis by making better decisions about transplant and giving them more than 5 minutes worth of transplant education at 4:45 a.m. But I digress. I got you, Quinn. I made you smile there. So Roma, we had talked about this previously. How do you see that occurring? Do you think that that would be a conversation with me and Dr. Benedetti as the leaders of the project to talk directly to the largest dialysis providers in the area? Or do you think that's a relationship that exists with the ESRD network that you guys can leverage on our behalf?
th- there's a couple of ways that we've done things in the past. I mean, I'll have to run it by Audrey. One, I mean, I guess if the main objective is to reach out to the facilities themselves or the social workers, if we can get a list of the specific facilities and kind of try to set up some kind of meeting where you guys can talk about it, to maybe give them an idea of what you guys are doing and how the facilities can participate in it. We've also sent out communication on certain organizations' behalf, and just say, hey, there's this program out there, we encourage you to participate, so those either email send outs, or if you do want us to maybe try to set up an appointment or a meeting with the facilities, we can try to do that.
You believe this has to be a facility by facility approach? Because it's a lot of facilities on the south and west side of Chicago.
I mean, I guess it would introduce them to the project, and, maybe kind of encourage them to participate if they hear about, what the goals or what the intentions are. It might open up ways that the social workers would be more involved in saying, hey, I've got this patient, if, you're interested in participating, kind of getting them that way. I mean, or we could reach out to our regional leadership also.
Do you guys have any kind of annual meetings that they attend that we could get in on, if that's in the time frame that we need?
I mean, we're starting our new contract on May 1st. So we are gearing up to schedule, our meetings to kind of introduce the facilities to that. And we also have regular regional meetings with the regional LDOs. That would be DCI really doesn't have any facilities in Illinois, but the DaVita and the Fresenius, I know we meet with them on a quarterly basis. So, I mean, that's something that I can talk to Audrey about. But we've set up different meetings, specifically, specifically inviting facilities in the zip codes or specific areas to join in. So
I would love for that to be Plan B, and the individual visits to transplant center, to dialysis centers, to be Plan C, if at all possible. I'll let me leave that up to the group. I hear what you're saying about the relationships and the social workers getting on board. I just feel like it's a heavy lift.
okay.
I mean, it's a heavy lift if it had to be me trying to get to all of these. Is this something that you feel like it'd have to be the leader of the research, or is this something that perhaps we could give to our patient members to do some visits and pay them to do it? Uh-oh, I got some looks. No? Oh, I'm sorry, Bella. I'm sorry. It's cool. Cool. All right. I guess so. Like I said, option 3.
Well, and then one
I
thing
have no problem.
too, I don't know if Audrey talked, so part of our new contract is we are going to have a staff member do site visits to specific clinics starting, well, I guess we haven't technically gotten the final final contract. So yeah, we do have someone. So I was talking to Audrey earlier about like if we can pinpoint which facilities, you know, which area, and kind of give you a list of which facilities are in that or are part of the list of facilities that we have to do site visits, you know, on. That could be something too that we could look into. You know, at least it's one of our people that's already going to be at the facility can, you know, talk to someone face to face, and part of our site visit will include talking to patients too. So
Okay. Can you circle back with Audrey and then let me know? I'll be happy to jump on a call if we need that, or we can handle it via email. Just let me
Okay.
know. I have a meeting next week with the head of EQRS and the grant representative from CMSOMH to see what we could do. But it's looking less and less likely at this point, which is disappointing. But hey, I got IRB approval, so I am not gonna let them drag me down today. Okay, thank you, Roman.
I have a couple
Billy,
of
go
a
ahead.
question here.
Yeah,
I missed the previous meeting, so I may be sorry if this has been explained.
it's okay.
I heard you the previous exchange about reaching out to patients in the dialysis units.
Mhm.
Have you spoken to Ben Hippen?
Who's that?
Ah, that's the name you need to know.
Okay.
Ben Hippen is a transplant nephrologist who is now the vice president, the global vice president for Fresenius. And he remains very active in the transplant community. He's, in other words, he runs the whole Fresenius unit enterprise in the country. And if you want advice as to how to contact or get access to the Fresenius units, which I will tell you are the most difficult units, at least in Michigan. They are the most difficult units to get into. He will be a good person, and I can give you, you can actually look him up in the AST. He's a member of the AST, director.
Oh, I'm not a member of the AST.
Then I'll give you the contact, okay?
Very helpful.
So the next question is, when we have tried to do this, we have gone and talked to the regional managers of the different
Of the dialysis centers.
Yeah. So when we wanted to expand and you sort of start a protocol to try to get patients transplanted, we decided to go with DaVita because DaVita is the largest dialysis company in the state of Michigan. So we met with the regional managers. It's a Great Lakes regional manager to try to figure out what was the way to approach it. So if you think it's appropriate, it may not be a bad idea. You don't need to reach out to Ben, but you can try to find who are the regional managers for the dialysis units in the Chicago area,
Mhm.
And then introduce yourself and try to schedule a meeting with them. It's also always easier if people in management are willing to help you out.
Yeah, you're absolutely right. I think that would be probably that plan C. I think that if the ESRD network has the relationship and they're willing to let us kind of piggyback off of their relationship with those dialysis centers, that's the easiest way in. If not, then yeah, definitely talking to management and then working our way into the regions as opposed to trying to work into each individual dialysis center. I would agree with that.
Cool.
Very helpful. Thank you, Millie.
You're welcome.
Any other comments on that? All right. Let's use the last of our time looking at the spreadsheet that I sent you guys. Move this over to the other screen. See, that one moved to the other screen. I don't know why the other. Now we share screen two. Okay, let's make this just a teensy-weensy bit bigger. So can everybody see this okay? What I will say is that we spent a lot of time on the clinical leverage points last time. And again, for those who weren't with us last time, the interviews with each of the transplant centers yielded things that the transplant centers thought they did well, and a few things that they thought that other transplant centers did very well, and were the basis for referral mechanisms. These were the things that I thought might be leverage points or parts of pieces of information that made the patient feel that one transplant center was better for them than the other transplant center. So we pulled out those different leverage points and started having a conversation about them last time. We started with the clinical ones, which was BMI, lupus, sickle cell, history of cancer, amputation, highly sensitized individuals, diabetes, hypertension, HIV, Hep C, and arterial calcification, heart disease, LVAD, and liver disease. Those red box, or what is that, fuchsia? I don't know. Those reddish boxes are where I said, okay, we need a metric to say that we have information that we can add to the database in order to say this isn't just something that somebody says they're good at, it's something that we can prove that somebody is good at. So I want to go through these boxes and you guys tell me if you can think of a metric that we could pull to figure that out. So with highly sensitized, I thought, I just, from the conversations that I've had while I've been in this, I've heard that if you've had a blood transfusion, if you've been pregnant before, or if you had a previous organ transplantation, those are those rote identifications that would allow for you to say, I might be highly sensitized. That doesn't mean you are highly sensitized, but you might be. So is that an appropriate question to ask an EPEC participant to think if sensitization and that is a specialty in the transplant center is reasonable?
I think I would say it's reasonable.
So what is the indication that, because right, as far as I can see, the OPTN data does not say if a patient was highly sensitized or not. So it's not something we can check from OPTN data. So how could we get objective data that says that somebody is better at taking care of patients with a high level of sensitivity?
If you really want to get that data, that you need to look at the CPRA, the panel of reactive antibody. You may not know why the reactive antibody panel is high. It may be that the patient, if it is a man, it's easy, right? Because it's not pregnancy, you can exclude that. It may be a previous transplant, or it may be blood transfusions. All the centers have information about the CPRA, which is the calculated panel of reactive antibody. And we need to know that because by being sensitized, you get points to be transplanted. I don't know if this is sort of answering your question.
It is. So I think Sanjeev and Pierre Paulo, you guys have worked with OPTN information before, right? Is that in, I didn't look for CPRA specifically. Is that in the OPTN information? Do you guys know?
Yeah,
Oh,
I
it's
mean,
in UNOS. It's
I
in
agree.
UNOS, and you will have it by individual patient name.
Yes, it's on UNOS data and stratified by also unacceptable antigens, and you can get CPRA pretty. It's reliable. It's for every single patient. Yeah.
So what, is it a certain percentage of patients that we would say, okay, so the top 2 programs with the highest percentage of patients with the CPRA over what?
Yeah.
Is there an objective number?
Yeah, on UNOS data, you can locate each center at the center level and then stratify by CPRA, by whatever you want, you know.
I'm asking you guys what it should be, because I don't know.
That's a good point. UNOS data provides the details. I'm not entirely sure if goes to the patient specific. Maybe they will give sort of UNOS number which refers to the patient, but it can be.
So we're not trying to identify the patient.
If I can add something to that, each transplant center has access to UNIT.
Yeah.
UNIT is a patient-linked software that you need to review to update the clinical conditions of the patient. You have access to demographics. You can access the patients by UNOS number.
Yeah.
And that will give you a fairly good information about the whether the patient had a previous transplant, whether the patient is a liver and now is getting a kidney, or a heart or a lung. So
that's the hard way to do it. We could just ask the patient, right? The patient is a participant, so we'll already have them
don't know if they are sensitized. The majority of the patients do not know.
They don't know usually. Yeah.
Yeah.
But the only way for them to have that number in that system is if they've been evaluated, right?
Yes,
We're trying to
correct.
get the patients before they're evaluated. So we'll ask them, do you have a history of transfusion? Have you been pregnant, or have you had a previous organ transplantation? That's what this column is for. That's going to give us a rough understanding of whether they're sensitized or not. So the very specific question is, what level is highly sensitized? If I'm looking at a PRA number, what level is my line of demarcation as to whether they are not sensitized or they're highly sensitized?
You know, on honest, I think a good number would be above 85%.
85, perfect. Everybody
I don't know
agree
if
with
the
that.
others would agree.
What sensitization is something that you calibrate.
Yeah.
Or if you want to use the value that the trials use, sensitization is anything above a CPRA greater than 20%. That's a sensitized patient. A non-sensitized patient will be a patient below 20%. If you talk to people like me, for instance, which I have done this all my life, I consider 10% a level, anything above 10%, the level of sensitization. Now you have the highly sensitized patient, it's not a sensitized patient. And those patients, as it was said, is a CPRA greater than 85%.
Okay. Perfect. All right.
Ernest,
So
I just want to, can I just make a comment about the information that's in UNET is only going to be in there if the patient has been evaluated and has been
Correct.
accepted, and a TCR transplant candidate registration form has been completed. So most
yeah,
of the
we
patients
covered that
that we're looking
already.
at.
So that was I didn't know
voluntary.
that you were looking at patients before they are ever listed.
I got you.
UNET
move
is
on to the
only
next one.
for listed patients.
Right. So arterial calcification is something that we came up with as well. I have no idea how we are going to track that. Do you guys have any ideas on that?
Then you can ask the patient and see if they have amputations. You see that in all diabetics. If they have amputations in their feet, they have arterial calcification.
Is that as gross as we can get? Is there anything?
The other way you will have to is look at imaging. A patient will not know. I'll tell you, Ernest, when these guys come here, even if they have had an amputation, they don't know why. You know, so you need to get into the medical records when you are evaluating these patients. You may find someone, you can also ask them if they have had any kind of vascular surgery done in their legs. And they will know that. Yeah, I had a stent, yeah, I have a bypass. That's calcification as well.
So not in the heart, but in the periphery.
In the periphery. If you want to know, they certainly will not know anything about calcification in the heart unless they had history of a heart attack and have had either bypass surgery or a stent placed.
So
And
how do I identify which hospitals have objectively done more patients with arterial calcification?
You want of the centers that are participating in your study? Or
I'm
any
sorry.
center?
No, the centers participating in the study.
They should be able to provide you that information. You know,
So I'll put it on the questionnaire, but what
so let's say
specific question?
if your center is using EPEC as the database, the only thing the center has to do is to enter diagnostic codes, ICD-9 or ICD-10. They enter the code for kidney transplant. If you want to add pancreas, you add pancreas as well. And these will have to be patients that, I guess it will not be kidney transplant or pancreas transplant because they have not been transplanted. So
Right.
what you need to do is look at ESRD. And it's an ESRD code, enter a coronary artery bypass grafting code, and enter, will be the best code to look at.
Wait. So let's back up. Because so this column is the information that tells us which of the transplant centers are currently doing that work. This column is about what we ask the participant who hasn't been evaluated, what they're doing. So we've got this one down as to what we asked the participant. So and I was thinking that this was an EPEC pull as well. But let me ask the physicians that represent the hospitals in Chicago
Mhm.
is asking for a EPEC pull reasonable for this work. I didn't think so. I see
Oh,
Sanjeev shaking his
absolutely,
head.
absolutely. They have people who should be managing their database.
So Millie, let me ask the people who are in Chicago, the ones that are actually gonna do the.
I don't think you're going to get anything that has arterial calcification in our ICD-10 codes.
Not for arterial calcifications in the leg, but you can find peripheral venous occlusive disease. That is an ICD-9 code.
Yeah, I don't, but I mean, if a lot of the patients are transplanted, you know, or they're from outside institutions and we're just seeing them for their transplant, we may not necessarily, like, we'll document it in our MRB, but we may not necessarily put an ICD-10 code in there.
Well, they are probably about to close and go bankrupt if they are not using the right. They are not getting any kind of good reimbursements.
Probably not, yeah. That's probably the case.
So in any decent transplant program, because we all want money to keep functioning, you need to use ICD-10 and ICD-9, and these are pre, right? So we are not even talking about any of CMS involvement at this time. There is CMS involvement at the diagnosis of end-stage kidney disease and CKD. So if hospitals want to make money, the more diagnoses that you enter, the more money you get. And
So Millie, let me ask Pierre Paulo and oh God, did we lose her? I don't see Darshika. Oh, there she is, Dr. Chabra. Okay, Pierre Paulo and
I'm
Dr.
here.
Chabra. Yeah, I had to move my Zoom screen there. I kind of agree with Sanjeev. Can you guys think of any way for us to get to this specifically?
A simple question I noticed to ask the patient is the history of smoking. I hardly seen someone smoking without calcifications, you know. That's something you can ask. And also, you know, I agree that it's hard to detect, but our coordinators, they do report calcified vessels.
Yeah, look at in the record, the patient will not know that.
Yeah, the patient, I don't think will know, honestly.
But we're not asking the patient. This is the information we're going to ask the transplant centers to say.
We do have record of calcified vessels. Yes.
You have that in the EMR?
Yeah.
Yeah.
As an ICD-10 code or?
It's an ICD-10 code.
Peripheral artery disease, yeah.
Yeah, you want to enter PVOD because PVOD is one of the highest paying. Two reasons. It increases the risk of the patients that you are managing. So
Right.
your OE is more favorable to your
So Millie, I don't want to get off into a coding discussion. I want to stay focused on this.
Okay.
Is it possible for us to get an EMR pull from Loyola, UIC, and Christ? Do you guys think that is a reasonable request as part of this research?
I mean, we could certainly try it. I don't know what you'll get out of it.
I think we could try it too. I'm with Sanjeev. I think we could try it too. Like, we may not have it for everybody, but we might. You know, it's worthwhile.
Why not just use the UNOS PVD part in tie-dye? Like, why not just use what SRTR uses?
Because I don't know what it is.
But remember, these patients are not transplanted, right?
Yes, they are. So in this column, we're trying to figure out what the current practice is.
The SRTR,
does the TCR have it?
The TCR would have, what would it say?
I was just wondering, does the TCR have PAD in there?
Okay, so I will look up to see if the TCR has it.
And that's one of the the worst documented diagnosis. If you want to ask the patient, how's the phosphorus? How's his level of phosphorus? If the phosphorus, he says, oh, it's always high, chances of calcifications are pretty high. Have they told you anything about your PTH? They will say, oh, yeah, it's very high. You
All right,
can
let's
also
move-
ask them about the medications they're taking. Ask them if they are on Sensipar. If they are on Sensipar, they probably gonna have calcifications. Actually, the most important source of vascular calcification in dialysis patients is a high calcium phosphate product and high PTH level. So that will be your best way to get them, and they know their medications. If you want to ask the patient directly, that's
All
what I
right,
would.
so how am I going to identify the centers that are best taking care of kidney transplant patients with liver disease? Because we could ask them if they have a history of cirrhosis, or we could not ask them. We could look in the MR to see if they have a history of cirrhosis. That's not going to get it.
Oh, no, you can, I think that'll work. I think.
Oh, okay.
Yeah, no,
You shook your head. I didn't know.
No, sorry. I'm thinking of how you're going to capture it in from the center
Yeah.
standpoint, and that's going to be. I'm trying to think of like what you'll get from the OPTN data, and there's just nothing that really captures liver disease in the kidney forms.
And you're only interested in patients that potentially will get transplanted, right?
So again, in this column, we're trying to figure out the current practice. So what liver disease patients have been transplanted in the past 3 years per center? How do we identify that?
The problem you will have with that is that if you have cirrhosis, an advanced cirrhosis, that's a contraindication for transplantation, kidney transplantation. You can find out how many SLKs, simultaneous kidney livers, had been done. But that's also a slippery slope because people cheat on that kind of information. So it can be manipulated, especially now that the allocation rules have changed.
So is that the case in Chicago? Is cirrhosis a contraindication for kidney transplant? No.
Mhm.
Okay.
No,
Uncompensated cirrhosis is a contraindication.
It is, but that's okay at that point then.
Yeah, and then you can look at the SLKs, but it's tricky too. So
Right. But yeah, compensated cirrhosis not.
you can put a disclaimer when you write the paper.
I'm not writing it. Let's focus on the project now. So should we take number 14 out? If it's a contraindication for everybody.
I mean, again, it depends. Liver disease. I mean, yeah. Are you looking for? I mean, decompensated for sure. No, but compensated liver. I think there's going to be variability in practice in Chicago on who's taking compensated liver disease.
Yeah, remember that liver disease is going to increase the risk, and with increased risk, you also have risk of graft loss and patient death.
We're trying to be focused on the patients that are single organ kidney.
Mm-hmm.
So I don't want to veer off into SLK. Are you saying that a compensated a person with cirrhosis but is compensated, we would do a single organ transplant, or they would still be a SLK?
Mm-hmm.
Correct.
You
You
would.
can do a single organ, but again, as Sanjeev says, it's going to vary among centers.
Right. So what is that? Is that something that I can objectively identify in data?
If you want to know the status of the center should be able to provide that information.
How? What is the question I asked?
Well,
Just do they have parameters for cirrhosis, transplanting cirrhosis?
yeah.
But that's subjective though, right?
And
Everybody
I mean,
has
no,
parameters.
if they have it in their protocol, I mean, like we have specific guidelines in our protocol that state what you need to have to be transplanted if with compensated cirrhosis. Like you have to meet certain criteria to have that. So I would just address it as a questionnaire and just say, does your center have a protocol for cirrhotic patients, compensated cirrhotic patients?
That is requested and required by CMS. We need to have an inclusion and exclusion criteria. And each inclusion and exclusion criteria then needs to have a protocol. Each center should have that in their website that is exclusive for the password protected websites.
Okay, that is all of the clinical ones. So when we get the non-clinical, I think I'm good on compliance, social support, frailty, physical fitness, and substance use. Cognitive ability and health literacy came up last time, and I'm pretty sure they were Dr. Josephson. I can't remember who brought that up, but how do we identify which centers are less restrictive based on cognitive ability or health literacy?
Inclusion criteria again. Now, there is cognitive and cognitive ability, right? So many programs would say they do not transplant documented patients with dementia. But that's not the only level of cognitive activity. We don't classify, at least in my program and the programs I worked before, we don't classify cognitive ability by grades. As long as the patient is non-demented, doesn't have to be a rocket scientist. You transplant them, and then what the psychologists say is that this person has limited neurocognitive function and has to be accompanied by a relative to the visits all the time, and needs to have always someone supporting them in taking their medications. That's all there is.
Okay.
Ernest, I just want to let you know, I put in the chat the information from the kidney TCR forms. There is a question about peripheral vascular disease with the options of yes, no, or unknown. And I also entered the link for that form for you.
Perfect. Thank you. I'm not going to the form. I'm going to go straight to OPTN and say, give me the data. I got it. So both of these are questionnaire. We had said that multi-organ transplant was a leverage point, but our research is really focused on single organ. So are we saying that if somebody is going to need a kidney and a heart, that the leverage point is we're going to say you need to go to a organization that has a combination program? Or are we saying that actually
most likely they're probably plugged into one of those programs for the other organ, and the kidney is usually the secondary organ. So like if they need a heart kidney, lung kidney, they're already probably plugged into one of those.
Would they be on dialysis?
Yeah. So I mean, for those, I don't know if you're going to have much influence. I mean, that one is going to be tied probably to whatever the main organ.
Yeah.
That in failure.
I agree.
Yeah, that's going to go there. So
let me ask the patient representative specifically, if you were on dialysis and somebody came to talk to you about this, about where you go to get a transplant, are you looking for, are you going to be happy with information about multi-organ? Or are you going to say, I'm already, none of you guys were multi-organ though. right? We were all single kidney, I think. Danny, were you multi?
No, I just received a kidney transplant, but I mean, if I am a patient, and I'm sorry, I'm off camera. I just
Okay.
walking out of the office today, kind of crazy day. If I was in search of or needed a double transplant, I would like to hear information from a provider where it happens most often, I suppose. But I mean, being a single transplant, I mean, it's hard to say.
So then it wouldn't be a questionnaire about which organ combinations they do. It'll be more about the volume of multi-organs that they do.
Yeah, I suppose I would probably want to know like what institution or what hospital might have a higher volume of dual transplants as a collective unit, as a unit, a transplantation unit, versus like, oh, this hospital does really well with heart and whatever the second is. I just want to know like which team of doctors and physicians are so well equipped to sort of do double transplants. I mean, maybe they might be able to do whichever ones I need because they do it so often.
So I do actually know a couple people who've had multi-organs. I know a guy who had a heart, kidney, liver transplant, and then another guy who had a heart and a kidney. And
Heart,
just,
kidney, liver, they got all the organs.
man, his story is crazy. But talking to them, I do know that their concern was how efficient are you? Like, how well can you handle this? Not necessarily do you specify in just heart, lung, or something to that, or kidney, heart, but more so, how well versed are you in doing multi-organ donation?
Which
And
is
that's what I
all.
was gonna say.
Okay, go ahead, Della. Go ahead, Della.
No, I said that's what I was gonna say,
Oh, okay.
because I know I would did my research on, their proficiency, who are they, how well, what's the stats on them as relates to, just that type of multi-organ transplantation. I would want to know that, but that probably be a little bit more in my own research. But if somebody just came to me in the facility, I'm sitting there trying to get my treatment done, and they just talked to me about transplantation and multi-organ. I don't know if I would be in the right frame, mindset to want to listen at that point in time, as opposed to give me literature, let me do my own research. That's sort of kind of, it's going to be a little bit individualized to each his own person.
Let me stay with the patients. Have you guys heard of transportation assistance? I mean, I'm trying to figure out, for you trying to get to the transplant center, either for evaluation or for clinic visits and stuff like that. I'm trying to figure out what the metric would be for us to say somebody that has a issue with transportation, you should go here versus you should go here.
Well, that's a problem right now, just in general, just getting transportation to the clinic. So, that's an issue across board. I know that when it came for me to possibly consider going to Wisconsin and looking into their program for considering getting transportation, getting transplanted, transportation was not even on the table. It was a situation where I would have had to find a way to get there. That was number one. And one of the things they recommended to me is if I did get transplanted, that I need to live out there for at least 6 months, so that I could be able to get back and forth to their transplant center, as opposed to maybe just doing long distance driving. And so that alone stopped me from even considering them. And even
so here locally is the important part.
Right.
Here locally are there any?
So yeah, several things along that line. So transportation was never ever on the table, even locally here, to get me back and forth from my clinic to there, or even the place. It was something I had to make sure all of that was in. I had to work it out.
So Sanjeev, Pierpaolo, Darshika, have y'all got any entree into programs specific to transportation? Because I've heard that transportation is quite a contraindication, not an absolute, but quite a contraindication for.
You know,
for this.
Ernest, it's just as important as social support. So, you
Yeah.
know, it's important that they have a plan in place, or if not, you know, that they come up with a plan to be able to get transplanted.
Yeah,
Because the risk is very high if they don't have, you know, an ability to go back and forth, especially after transplant for their clinic visits and things.
Go ahead, Pierpaolo.
yeah, I do agree. I mean, that's something required for follow-up also. So that could be a limiting factor. Yeah.
You know, I understand this about myself. I'm doing everything that I can to keep access as open, wide open as possible for every participant that comes through. But everything that I've heard, not just today, but previously and outside of this group, is if we ask them, do you have access to or have your own car? And they say no, that it's you need to find transportation before you go get listed. Is that a fair assertion of this situation?
Yeah, it is to me, because they told me I had to find transportation. That's the first thing they asked me. How would you get to the clinic? How would you get to the hospital? Do you have that in play? You know, who's your person? You know, that was one of the main things that I had to show proof that was not going to be a problem getting there, or that I have a support person.
Correct. Yeah, I was in that I was mentioning that as well. They are huge on not only finding out if you had a way to get back to the hospital you were transplanted at, but also what kind of care you have at home as well. So when you go to see your physicians after transplant, if you're going to have this extended care after you get back to home, those are two very important factors that University of Chicago sort of focused on for me, even throughout transplant. You know how when you go back for your evaluations as you're waiting, that was the first couple questions I was asked even before looking over blood work and everything, to be quite honest.
Yep.
So this is the first one that we've got to where I've got nothing to say. And I don't think so. What I mean is I don't have anything to tell the UTP, right? You ask the patient, the participant, do you have transportation? They say no. What do we say?
They have to. I mean, it's important. I mean, as a patient, you should. I mean, you want to go to see your doctors. I mean, you want to make sure you're doing the right things. You want to answer questions. You want them to check the wound. You want them to check everything. I mean, you want to be at the hospital, especially right after transplant. I mean, it's something that you should want as a patient for sure. I mean,
you didn't answer my question though. Do we just say this isn't for you? I mean, that's harsh, but it sounds like it's a reality.
It is harsh
because with Medicare or Medicaid, doesn't that covered? Is transportation covered through, the Medicaid they receive for being an end-stage renal patient, and that can be worked out?
No.
Nope.
I never heard that.
No. And it is harsh, and it's really one of those mindsets, really damning mindsets, to the point that you started thinking, oh my God, I'm not going to get transplanted because I don't have good adequate transportation. I went so far as to say, would it be allowed for me to use Uber? And it was just to that point, just in case, because I could not guarantee in the beginning. And they was like, well, we're not sure, but we will work on that. We will see. It was that type of response. It just happened to be that I'm thankful that I had a support system with my church that wind up, when they heard I had a transportation issue, they paid for people to come and get me and take me. So, but you got to look at an individual who don't have that extra. I was just very fortunate because I didn't have it in the beginning. But that is one of the things that's very damning, and it's nothing they say. They like, can you see you can work on it? Because that's exactly the response that I got. Can you see you can work on it? And that pressure was put on me, not on the person, the clinician or anybody else, or a CMS or Medicare or Medicaid.
Let me go back to the physicians, because this is one that we talked about in the patient meeting previously, where we were talking about the turnaround time. And when I did the interviews, I heard a couple of sites say that we got a goal for the turnaround from when you call to when you're scheduled, and we got a goal of the time that it takes before your evaluation is completed and you can get a determination of listing. But the patients were very vocal in saying, I don't care about your goal. So now it's a question of, it sounds like asking for an EPEC request for the arterial calcification is not out of the question. Is this something we could add to an EPEC request to say, for the patients that you've seen kidney only in the past 3 years, what is the average difference in days between their first visit and their listing? Is that I don't know if that's evaluation. Well, we can figure out what the dates are. But is it something that's reasonable for us to ask in an EPEC request?
I think so. You probably could get even from most quality meetings. The institution's probably following it, or the programs are probably following what their actual times are. So it's probably a reasonable one to get.
I was trying my best to stay away from EPEC. Okay, I got a couple more red ones down here. So location and ease of access, things like parking, seem to make a difference for a lot of patients. But how do we identify which sites are easier? Because it seems like it's a gross answer to just say Loyola and Christ are easier. But it feels like it's the right answer. So
it is the right answer. I don't know what you're saying.
Stop, Sanjeev. Stop yourself.
I agree with Sanjeev.
Here, Paulo, we know it's hard to get to UIC. We know it's hard and expensive to park at UIC. I don't think this is going to be a leverage point that people say, this is my number one, but how are you going to feel if we say, if that is your number one, which it'll probably be a very, very small minority of patients, to say you need to be focused on Loyola or
well, if they have
Christ.
a park, probably is best there. No, I don't. I never consider that, I have to say, but of course it's good consideration. Yeah.
That's because you got your own private parking space, Dr. DeCoco.
Yeah. There are some free parking, but we share with Rush, and then there are several hospitals around. So yeah, it's a little harder. Yeah.
Okay. I'm just gonna say gross assessment here. I'll get to that later. Ease of contact is another one of those, and I'm sorry to say I can't say that it's just Christ and Loyola on this one. So is there being able to get in contact? And I'm pretty sure it was Quinn. I'm pretty sure it was Quinn. The ease of getting in contact with my doctor is critical to the relationship that I'm building with this transplant center. Obviously, as a patient, I've only been involved with one. As a patient, we've all only been involved with one. So how is it that we would be able to gather data on ease of contact? That's for anybody. I don't know.
Now,
That last question.
and Erna, I hope this answers the question, but I mean, I would receive calls pretty often from transplant center just to make sure that the contact information that I had was still current while I was on the waiting list. In addition to like the questions I would receive about transportation and so on when I will go in center. So I would get calls just to make sure the contact information was all still legit, sort of throughout like my waiting period, if that answers the question.
You would get calls from the transplant center just to give you updates?
Yeah, I would. I mean, I don't know if anybody else who got transplanted from University of Chicago, but the transplant center would call me. I think maybe monthly. It was that often at some point when I was getting closer to like being on the top of the UNOS, just to make sure that contact information, emergency contact information, address and anything like that was asked of me sort of often, if I remember now, like especially as I got closer. Yeah.
So yeah, we did get those calls. It was from a third party company that the hospital contracted to make sure, and they were called our some type of coordinators. But that was their job, to check in with us monthly to make sure that our contact information was up to date. Make sure we hadn't had any hospitalizations. Everything, our labs were still good, like just to check in to make sure you're still okay to be on the list.
Northwestern does it too.
Yeah.
Okay.
But from what I was saying, ease of contact with my doctor. That's what we're talking about, ease of contact.
Yeah.
It was more so the other way. So when I first got transplanted at the university, I didn't just have one doctor. It would be a rotation of doctors. And so my concern was, I know that if I reach out to Dr. Josephson, she's going to give me a call back at that same day. But if I have another doctor another day, do I have to wait 2 or 3 days to hear back from them? If I have a fever, which I did, when I got that fever and I called the hospital on a Saturday afternoon, how quickly was I going to get a response back to tell me what I needed to do? Should I just drink cranberry juice because they think it's a urinary tract infection, or do I need to just go straight to the hospital? That's what I meant by ease of contact. How quickly can I get in touch with my team if I feel like something is going wrong?
I got it. So it's both ways, and I understand. I threw that in there. There was literally only one question left, but I don't want to keep y'all any further beyond 5 o'clock for y'all. So thank you. This is exceptionally productive. That's why I'm making an hour and a half, because we're never going to get done in an hour. Thank you all for your time. There's so much more to come, and we will be in touch with you guys very often by email for the next month or so, as we get these contracts started and hopefully signed and get these surveys out the door. So thank you all, and we will be in touch soon. Questions, I will hang around for a few minutes afterwards, but thank you.
I was
so
gonna
much.
say, you wanna chat?
Thank you.
Yeah, I'm gonna hang here. Thank you, Millie.